Hello, I'm Dr. Colin Black, anesthesiologist, and welcome to the second video in our Basic Life Support course. In this video, we'll be discussing Basic Life Support sequence. If you recall, we introduced the chain of survival in the first video, and a lot of emphasis is put on this in the most recent guidelines. So remember, the chain of survival includes early detection of cardiac arrest and sending for help. It involves early CPR and early defibrillation if possible. And if these things are done effectively and quickly, then we substantially increase our chances of survival from cardiac arrest. So the first things to consider when we're approaching a victim encountered in any scenario, I always think of the 3 S's. So we have to think about scene safety. Is the scene safe for the victim or the rescuers or any subsequent rescuers, as we do not want to deal with any further injuries to staff. We approach the patient, shake them gently on the shoulder and assess for any sort of response. And depending on the situation, we may need to send for help immediately or send for help after a further time of evaluation. So in this video, we will see a rescuer approaching a patient, kneeling on the ground and gently shaking them on the shoulders and assessing for any response. Let's consider what we will do if we find a responsive victim in the street. So if we do find somebody injured or unwell on the street, we should not move them. We should be prudent to not cause any further injury or disrupt them in any way. If they are awake enough and conscious to provide some information, now would be a good time to assess some of the symptoms that they may be describing, or to consider anything in their medical history that may result of them being injured or unwell. We should also at this point seek help, that either by yourself ringing emergency medical services with your mobile phone, or if somebody is nearby, asking them to call for assistance. And we should always constantly reevaluate the situation. Just because a patient is awake and conscious at one period doesn't mean that they won't deteriorate subsequently, and you may need to change your management at that point. If, however, the patient is unconscious, we must consider a few alternatives. Again, we must always send for help. The latest AHA guidelines has considered the fact that the majority of people now carry a mobile or cellular phone, so in all likelihood they will be ringing emergency services from their own phone. This is recommended, and it means that the patient is not left unattended, and it means that somebody can call emergency medical services a little bit quicker. It is recommended that if you have a speakerphone function, that you should always have this on while discussing with the medical dispatchers, as they will be able to provide you advice while you are providing CPR, and similarly you can talk to them through the speakerphone function. So this is something that should be done quite early in the sequence. If the patient is unconscious, we should put them in the supine position. So what this means is a lying position facing upwards, because this is the position that will be providing CPR and providing rescue breaths. Once the patient is in the supine position, we must open the airway with what's called or described as a head tilt chin lift maneuver, and I will demonstrate this shortly. After we have opened the airway, we must examine for whether the patient is breathing normally and assess the adequacy of their breathing. So we look at the chest to see if it is moving and expanding. We get down close to the patient and listen for breath sounds in our ear, and also we can feel expired breath against our cheek. Once we perform these 3 maneuvers, what we are trying to determine is whether the patient is breathing normally, whether they're breathing abnormally or not breathing at all, and this will affect our further management. The look, listen and feel maneuver is a little bit contentious between the ERC and the AHA. The ERC does still recommend that you perform a look, listen and feel maneuver. However, it should not limit or should not stop you from performing CPR. So it should be performed quite quickly and not interrupt or not postpone the commencement of chest compressions. The AHA, on the other hand, recommends that if there is an unconscious patient, that you should just start with chest compressions, particularly if you are an untrained or lay person. If you are a trained medical staff, then they do recommend that you can check for breathing. But again, it should be done very rapidly and not delay the onset of chest compressions. Checking for a pulse is not recommended for untrained staff. However, healthcare staff, you may check for a pulse, usually a carotid pulse, but again, this should be done simultaneously with assessing the adequacy of ventilation and should not be performed for longer than 10 seconds. Here we see the head tilt chin lift maneuver. So our patient is unresponsive. You see our rescuer places their left hand on their forehead and tilts it gently back, and their right hand, you'll see, is lifting the chin. We are listening and feeling for breathing here, so the rescuer is feeling for expired breath against the cheek and is also listening for any expired breath sounds against their ear. In this position, you can also see if the chest and thorax is moving adequately. So if our patient is unresponsive, but they are breathing, again, the first thing we should always do is seek help, so a call to the emergency medical services. In this situation, however, we should place the patient in the recovery position, and we will describe how we do this shortly. And again, just because they are breathing normally doesn't mean that their breathing will subsequently become will remain adequate, and it can change at any point. So we should always constantly reevaluate the situation and see if the patient's breathing is adequate. Here we'll see our rescuer placing somebody in the recovery position. So they're supine already. So you will see the rescuer placing the hand closest to them at 90 degrees above the patient's head. They will place the leg that is distal to them in 90 degrees and flexed position. The hand on the far side will be placed underneath the face of the victim. And using the leg and the shoulder, they will be rolled into a position here where you will see the hand supports the airway and the knee and the other elbow supports the patient so they don't roll completely into a prone position. The hand that is placed underneath the chin should allow the airway to remain open, and if there's any vomiting or debris, then the patient will it will come out of the mouth and there will be a minimal risk of aspiration. The most recent guidelines have introduced a new idea that is of naloxone in this particular population. So in unresponsive victims where there is normal breathing, one of the commonest reasons for this is an opiate overdose. And the AHA have brought this into consideration, and they have said that naloxone could be considered for trained medical staff, so namely the emergency medical services could consider providing naloxone in an intramuscular or intranasal or even intravenous dose if it is possible. So for those not familiar with naloxone, it is an opioid antagonist, so it should very rapidly reverse the effects of any residual opioid. And if this is the cause of the abnormal breathing pattern, you will quite often see a very, very rapid reversal and the patient becomes conscious and coherent quite quickly. They haven't described this particular dosing, the particular recommended dose or how it should be given, but I wouldn't be surprised if the subsequent guidelines do give further guidance on the use of naloxone in this situation. Now we will consider what happens in the case where the patient is unresponsive, but they are also not breathing. So this is classically what we would describe as a cardiac arrest situation. Again, as in other situations, we should seek help. So by using your mobile phone, by asking other people who are nearby to alert the medical services. Having carried out our breathing evaluation and pulse check already, the next priority should be to start CPR as early as possible, but also if there are sufficient numbers of people in the vicinity to alert somebody to get an automatic external defibrillator if one is present in the nearby location. So we should begin by performing chest compressions. So chest compressions should be performed by placing the one hand in the middle of the chest with the other hand on top of that one, and placing our weight completely down into the patient's middle of their chest and allowing full recoil. The guidelines suggest that 5 centimeters is the optimum depth of compressions whilst allowing full recoil, and the pace that we should aim for is about 100 per minute. It is often difficult to count 100 per minute, but just think that this is what our target should be, and no faster than 120 per minute. So here you will see a rescuer providing some chest compressions. So they are looking and feeling for breath sounds at this point. So eyes are on the chest. They're trying to feel if there is any breath sounds. You'll see the hand is being placed in the middle of the chest. The other hand is being placed on top of it with the fingers interlocking. The rescuer should shift their weight forward so that their arms are locked out completely. Position we do not want the hands to be in is over the abdomen or over the top of the sternum. We should really be trying to place them in the middle of the chest. So with locked out arms, the weight is being pushed down through the chest, but allowing full recoil at all times. If we are trained, we should aim to provide rescue breathing in conjunction with our chest compressions. Lay people or untrained people, chest compressions only is permissible, and we will discuss that shortly. However, rescue breathing in trained hands is recommended. So rescue breathing should be performed in a ratio of 30:2. So that is 30 chest compressions, a pause, 2 rescue breaths, and then subsequently restarting chest compressions after that. It is recommended that every breath should be 1 second per breath, and we should spend no longer than 10 seconds in providing breathing. So that is 30 chest compressions to 2 rescue breaths, and minimizing interruptions as much as possible by performing or allowing only 10 seconds to provide our rescue breathing. As I said, this is a difficult technique at times, so it is really recommended only for trained personnel. So here you will see our rescuer is still performing chest compressions and is now moving after 30 chest compressions to provide rescue breaths. So the head tilt chin lift maneuver is being performed. They are pinching the nose of the victim and will now provide breaths through the mouth of the victim. Again, they can glance to the right hand side and they will be able to see if the chest is rising adequately with each breath. So 1 second per breath, 2 breaths for every 30 chest compressions, and do not spend longer than 10 seconds in providing your rescue breaths. After this, we immediately re-begin chest compressions. So as I said, we continue with a new cycle of CPR, and this continues relentlessly, or it continues for a prolonged period of time. The only time that we should stop performing CPR is if there is an AED available and there is a shock indicated, or if the patient makes very, very obvious signs of being awake, such as physical movement, normal breathing pattern, or actually awake and attempting to talk. Otherwise, we should continue CPR in this 30:2 ratio until the emergency services arrive, and they will take it from there. So if we look at a little algorithm here on what we should do in this situation. So for basic life support, the crux is determining if the patient is responsive. If they are not responsive, we should always send for help. Usually this will be via mobile phone, or if there is some other people around, we can send one of them for help. The next maneuver will be to open the airway and assess for adequacy of ventilation. This is what is recommended in the ERC guidelines. If it is not, if we are in America, the AHA guidelines recommend just progressing with chest compressions. However, in the ERC guidance, we should check the adequacy of breathing. If the patient is breathing effectively, we place them in the recovery position after seeking for help. If the patient is not breathing effectively, but they have a pulse, we should provide airway maneuvers and consider the use of naloxone for opioid overdose. Or if the patient is not breathing at all, this is where we go down our classic cardiac arrest algorithm and begin chest compressions in a ratio of 30:2 with rescue breaths if we are trained in that. And we will discuss the use of automatic external defibrillators in one of our subsequent videos. I did allude quite briefly on compression-only CPR. Several observational studies have suggested that lay people or untrained rescuers are occasionally reluctant to provide rescue breaths, either because they don't know how to do it or for various other reasons. In this scenario, it is recommended that they provide compression-only CPR, and anyone who discusses or talks to an emergency medical dispatcher over the phone will be instructed to provide CPR or compression-only CPR. There will be some residual oxygen within the bloodstream, so if we can build up a cardiac output by effective quality chest compressions, we will significantly increase our chances of survival for this patient. Chest compression or compression-only CPR continues until we have an automatic external defibrillator, and the only time it stops is if help arrives and the emergency medical services take over. If signs of life appear, so very obvious signs like physical movement, talking, or adequate breathing, or if the rescuer becomes exhausted. Chest compressions can be quite physically demanding, and you do get quite tired quite quickly. So if they're performing these alone, they should be continued until the person is exhausted. If there's somebody else with them, then they could swap roles to try and prolong the chest compressions for as long as possible. So that concludes a brief overview of the basic life support sequence, which is described well in our chain of survival in the AHA guidelines. I'd like to thank you for your attention, and I look forward to seeing you in the next video.